Good evening and welcome to the closing ceremony of the third edition of the Breast Cancer Action Month. This year marks the third edition of the National Breast Cancer Action Day as part of the Breast Cancer Action Month, organized to not only make people aware of breast cancer and improve the health outcomes of patients and survivors, but also to drive the momentum to raise awareness about Ayushman Bharat and other programs that have started to revolutionize cancer care in India. I'm Anisha Nair Thapan, your host for the show. IHW Council and Rapid Global Cancer Alliance extends a warm welcome to our distinguished dignitaries. The most common malignancy in women is breast cancer. 2 years ago, breast cancer patients, among other patients, were put in a challenging and terrifying scenario when the pandemic struck, with many of them being at high risk of getting the virus due to therapy that decreases their immunity. Their diagnosis and treatment got delayed, with overburdened hospitals unable to cope with the onslaught of heavy COVID caseload. Breast Cancer Action Month provides a chance to raise awareness of the disease and maintain it at the top of the public's priority list. It also enables us to highlight the difficulties and sometimes the hidden reality of dealing with this disease. Over the past 2 years, Novartis and IHW Council have successfully identified gaps and barriers to adequate breast cancer care and management. And this year, through a combination of activities that included a national level summit and targeted state level discussions with stakeholders from Rajasthan, West Bengal, Kerala, Madhya Pradesh, and Tamil Nadu, we aimed at focusing on localized scenario of breast cancer with solutions attuned to local specificities and experiences. The discussions involved an engagement with an array of stakeholders, from government officials to medical professionals and patient advocacy organizations as well. The National Summit took place on Breast Cancer Action Day, that is observed annually on 21st October and has been institutionalized by the Integrated Health and Wellbeing IHW Council and Novartis. And that was the first observed by the Honorable Governors of Uttar Pradesh, Madhya Pradesh, and Manipur in 2020. The summit also featured several stakeholders from the scientific and medical community, industry professionals, breast cancer advocates, and champions, all with an interest of strengthening the action towards breast cancer care. Now, to help us wave the way forward in addressing the challenges to breast cancer care and to reprioritize breast cancer awareness, we are joined by an esteemed panel of dignitaries who have not only contributed immensely to the space of breast cancer management and prevention, but have also helped to ensure the highest health outcome of individuals of our country. It gives me immense pleasure to introduce our panelists today. Please welcome Mr. Naveen Kumar, IAS, Special Secretary, Medical and Health Department, Government of Andhra Pradesh. We have Dr. Shona Nath, Director, Oncology Department, Sayadri Group of Hospitals. We have Dr. Pankaj Gupta, Chief Scientific Officer for Innovative Medicines India, Novartis. And we will soon be joined by a few more dignitaries. I'm happy to introduce Dr. Shomesh Kumar, Country Director, JHPA Group. We'll also be joined by Dr. Anil Cruz, Director, Oncology, Apollo Hospitals, and Dr. Jitu Lal Meena, Division Head of Service Provider Engagement, National Health Authority. A warm welcome to all of you. Thank you so much for joining us this evening to discuss this very crucial public health issue. Now, Mr. Naveen Kumar, I want to start with you. Now, usually our society is quite uneasy about discussing women's body publicly. And this shyness is not doing any good to the cause of breast cancer awareness. A greater level of readiness is required to battle the effects as a nation. In the light of the big incidents of breast cancer in India, could you help us understand the role of government or states in facilitating awareness about the disease? Mr. Kumar, I request you to please unmute yourself.
Yeah, so when you talk about, you talk with the right word, right? Awareness. When you talk about awareness, That's the first A of the 6 A's, right? Awareness, accessibility, availability, accessibility, and affordability, and the adherence. So the first two part would belong to the patients, and the next three would be again to the government. The last one again would belong to the patient. So awareness is the starting step for any healthcare procedure to begin with. So what we are trying to do is, if you ask me, if I have I'm the secretary for the government of Andhra Pradesh. If you ask me what is the number of cancer cases in Andhra Pradesh, I would not be able to give you a number at all. I think that would be the case with anybody talking to on the platform today. So we would tell you there is somewhere around 60 to 70,000 cases, and 20% of them would be 20 to 30% of them would be breast cancer cases. And what we popularly call as OBC, the common cancers, oral, breast, and the cervical cancers. These are detectable at an early stage and preventable also. That's the key. So which means that there's a lot of success rate if you are able to detect it at an early stage, and then we have an aggressive treatment towards the disease itself to reduce. So right now we are looking at the country at 95 to 110. That's an incidence rate per lakh of population, which is quite low. That's also an opportunity for us to prevent it. This is not the way you would imagine advanced countries like or developed countries like Europe or USA, where it is somewhere between 350 to 400 or 450 or so. So there is an opportunity here, which means and also the shocking news is that 70% of your cases report at an advanced stage, which means you can do little about it, right? So awareness is very, very important when it's little complicated in a way. I think there are a couple of doctors on the platform. It needs an adherence to a treatment protocol. It needs, you need to check them. And once the reduction happens and the proper treatment happens and you follow up with your treatment, there is every chance that you would survive it. I think there's a lot of couple of initiatives which are grown up by the survivors themselves, and to give this news to the world that there's a lot of hope and there is not the end of world, right? That's what when people hear this word cancer, they think that's the end of world, right? So that's also an interesting point. So what we are doing in AP is a couple of things which I had to mention. AP is the only state or second state which has done cancer as a notifiable disease, where we have a registry where we will record all this. And we also have a digital registry where all these cancer cases would be registered, and it will also give us an idea where cases are coming up. That's the challenge for any public health representative. So when you talk to people who are into preventing cancer, they'll easily tell you that more cases are coming in urban, and right now it is also moving into the urban, and slowly it will start moving into the rural cases. I think the concentration of breast cancer cases will be more in urban areas, and slowly it will start moving. So there's also an opportunity we can create awareness in the rural areas so that the numbers don't increase tremendously. It's a time bomb to explode, but we can always stop it. One more thing which we have started doing is we have started using this mammography is the only device used, or but it's not the gold standard. I think there are a couple of doctors on this thing, they will agree with me. So we are also using AI and ML. There is a technology which is called Neramai, which we are testing. So we are testing all our in fact we have taken it as a special initiative under the AP/AIDS Society, where we are testing all our high risk groups and also HIV patients, because who are more susceptible to the cancer, for breast cancer, and we'll keep a record of it. That's very important. When you also screen them, there's also important that we keep a record of them, go back and screen them again. It's not just that you did that screening once and leave it to them. So the role of the government becomes very, very important for one reason. There's also, I'll tell you, a very economic reason, logic behind it. If you are able to detect the cancer at an early stage, the cost of treatment also goes down. The reason, so right now, if you look at Andhra, we are spending around 570 crores to 600 crores per year only towards cancer. So this money could also be reduced in case if you do an early detection. So there is a strong need for preventive, strategies. I think when you talk about the continuum, it is prevention, treatment, and palliative care. So prevention is the key to stop cancer from becoming bigger than what it is. It's already bigger, so it's important that we should work on the strategies to prevent cancer at an early stage. So that's my opening remarks. I think we'll talk later.
Right. Thank you so much, Mr. Kumar. You've given us Andhra Pradesh example of cancer being a notifiable disease, Dr. Anil Cruz, I just want to understand what's the role of making cancer a notifiable disease? How does it impact, state allocation, plan allocations, and the utilization of health resources for breast cancer control and prevention? How does it change, how it is looked at and the resources that are allocated to breast cancer?
So basically, firstly, I must thank Naveen for some very insightful comments to kickstart this meeting, and thank you for having me on this meeting as well. Well, for any cancer control plan, for anything you want to do in cancer, you must have accurate data. You must know the incidence of the cancer accurately. You must know the type of cancers that you see in a particular population. You must know the stage of presentation. It gives you an idea as to where you want to utilize your resources and how you can effectively use your resources. Now, basically, that means you have to have a strong cancer database. Now, ideally, this is captured in the form of registries. A registry will tell us exactly the type of cancer, the stage of cancer, and the populations that are affected by these cancers. In India, we do have a National Cancer Control Registry program. It's been in place from the early 80s. But unfortunately, about 10% of our population is covered by these programs. The rest of the population is not covered by these programs. Now, contrast this to the Northeast. Suddenly so in India, the cancer incidence is about 100 per 100,000, 110 per 100,000. And suddenly we found that the Northeast has doubled the cancer incidence in the last decade because registry programs were initiated in the Northeast. Now, if you look at the coverage of the population in the Northeast states, the coverage varies from about 25 to 60 odd percent, as opposed to the rest of the country, which is only 10%. Again, we only have our registries in mainly predominantly urban areas. Rural registries are few. So whether you make it a notifiable disease or you strengthen your registry program, the bottom line is to get good cancer data. Now let's give you an example. As again Naveen said, problem. We have cervical cancer and we have breast cancer. So if we thought that oral cancer is a big problem, then we can do oral cancer screening. We feel breast cancer is a big problem, we can do breast cancer screening. You can target your resources. If you realize that cervical cancer is a big problem, you need to target cervical cancer vaccination. So that is how our allocation can be correctly used. So yes, whether you strengthen a registry program, make it notifiable, whatever you use, the bottom line is to get good data and strengthen your cancer control programs.
All right. Dr. Shona, now in this day and age, technology has made so many advances. We have sent a mission to the moon, and one on Mars is also gone. So why is data collection of these cancer registries only covering 10% of the population ex-Northeast? And what difference will it make? Does this show that perhaps a lot of the cancer incidents, maybe in the rural areas, under the carpet and not being really reported very transparently?
So I think the main problem is that every hospital doesn't maintain electronic medical records. It's not really available in the smaller cities, cities like Pune, cities like Sholapur, Kolhapur, the tier 2, tier 3 cities in Maharashtra, for example, where I come from. They don't have EMRs, they don't have data managers, people don't fill in Documentation is exceedingly poor unless it is done on a clinical trial basis. That's the biggest loophole I find. My biggest problem still today is, even though I belong to a tertiary care and we have a super EMR, is having enough time to get people to fill in the data properly. And very often you will have people who are non-medicals or people who are not, like conversant with the terminologies. Let's take, for example, breast cancer. They won't know what stage to put in. They won't know the important fields that they have to fill. So these are the smaller problems that we need to educate hospitals. People are also taking treatment or reporting to smaller nursing homes. That is happening in smaller cities, where of course data is not kept at all. So we just don't have a good sense of where the pockets, like Dr. De Cruz mentioned, of increased various types of cancer are more prevalent, the incidence is higher, and where we can target our screening accordingly. So these are the pitfalls to data management. And having said that, Mr. Naveen Kumar rightly talked about awareness. Now, you can have awareness. You can know that there's a problem in your breast, but that may not make you do anything or come forward for help. For example, today I saw a lady in the clinic. She's had breast cancer in 2016 on the right side. She's been treated of it. She's been cured of it. She's had a lump in her left breast for the last year and a half. She was too scared to come to me, and now it's just gone beyond cure. And this is a lady who has already been through chemo, who's already been through radiation. Now, if this is the story with someone who's been through the whole thing, can you imagine a person who's got a lump and who doesn't want to be diagnosed in the first place? So awareness is awareness, but we need to change health-seeking behaviors. That takes a lot of time in the community. You need to get the word out there that it is curable, it is treatable, come forward, don't hide at home. Whatever the breast problem is, come. So on our part at Sahyadri, every October to December, we run screening camps. We put up hoardings. We get in women with no issues coming in for screening. That's called opportunistic screening. We go around groups, we talk to them. And next Saturday, this coming Saturday, we will be conducting our 10th annual breast cancer survivors conference. We do it every year, the NAG Foundation and WCI at Tata. And this year it's at Mumbai, where we have over 300 to 400 women coming and experts talking to them. And it's people who are 5 years out, 10 years out, 15 years out of breast cancer diagnosis. So these are the kind of events that need to be promoted. And like you said, people need to know that you can survive this disease. It's actually estimated there are over almost 2 million breast cancer survivors in India today. So that's not a small number.
I'm sure it's more than the number of those who died of cancer.
Well, it's 50-50 in India now, 50-50. But we need to change that ratio. Yeah.
Right. So Dr. Shumesh, Dr. Shwana is saying awareness is great, but there has to be some market sensitivity so that people change their health-seeking behavior. So when we're trying to increase awareness and even trying to improve the access to breast health services, we need to plan now for how our health system will handle the increase in breast cancer concerns and detection of suspicious cases, because we've heard Dr. Cruz talk about what happened in the Northeast. In such a situation, what are some of the programs that can be introduced to address the human resource capacity, to train them in a sensitive fashion so that they inspire the confidence of people to change their health-seeking behavior?
Yeah, thank you, Anisha, for this question and for having me on the panel. So, adding to the very insightful thoughts from both the secretary as well as Dr. Anil and Dr. Shona. First, we have to recognize that this is important enough for dedicating and committing resources to integrate the entire breast care pathway, clinical care pathway, into the current health system. That is the first step. And then there is enough resilience in in most parts of our health system where we can incorporate and integrate the early diagnosis part of the breast cancer breast cancer programming in the current health system. So what we can do to start with for breast health awareness, and we are doing this at a significant scale, at a reasonably significant scale in multiple states of India, Uttar Pradesh, Madhya Pradesh, Odisha, Jharkhand, and one more state I'm forgetting. So in 4 or 5 states, what we are doing is we are working with the ASHAs and ANMs to encourage and increase their awareness about the 6 conditions under which there is a likelihood that the women may have a breast disease, and we are giving them job aids for them to reach out to the women during their existing planned visits, whether it is for reproductive health, family planning, or in immunization sessions, village health and nutrition day. They take this and they increase the awareness of the woman on 6 conditions, so that a training for these frontline healthcare workers is planned, and we do this, and it is pretty effective. The second, if you move up in the health system chain, you have the primary healthcare system, and that is the health system at the health and wellness center, the new primary healthcare frontier, and then you have the primary healthcare center itself. And so what we do, we train the auxiliary nurse midwives, the newly recruited community health officers, as well as the staff nurses in the clinical breast examination. And the recent evidence from India has shown that clinical breast examination is almost as effective as any technology-based mammography or any screening solutions. So we have trained them, and we have already gotten data that the screening rates through CBE is leading to downstaging of diseases. So these are some ways where you can increase the capability and the capacity of the existing health cadre with the principle of integrating the care pathway in the existing health system. So that
Dr. Somesh Kumar, is your data also showing that CVE leads to low mortality rate, or is it just downgrading of the cancer stage?
So we do not have that data yet because our programs have not run to that course. Neither do we have resources in tracking women. But from Dr. Barde's studies from Mumbai, and there is enough data that shows that the early detection diagnosis rates is much higher, 60% plus. So I think
using CBE.
and then CBE, early detection diagnosis through CBE plus plus.
Okay.
CBE, clinical breast examination, leads to downstaging. And then, as Mr. Naveen pointed out, if you detect them early, diagnose them early, then you have a very high chance of curing them, because then the system is resilient enough.
And then the cost is also lower, because
cost is also lower.
Cancer.
Yeah, cost is also lower, and then the system is resilient and capable enough to take care almost. But if once a woman is in the stage 3 and stage 4, then obviously the system's capability to take care of all these women from diagnosis to complete treatment to palliative treatment is pretty suboptimal.
Dr. Pankaj Gupta, while we are making a lot of effort towards increasing awareness, early detection, not following the set standard given by the West on how you should do detection, because their cases happen later, our cases happen earlier. Science still keeps moving forward. Science still keeps innovating, and we are not going to wait for the data to get better and more information to come in for us to adopt the latest, right? What is the role of private players or the industry? What role do they have in promoting and facilitating breast cancer early detection, screening, treatment, awareness? What strategies can we employ to enhance breast cancer prevention and control in India?
Thanks for the question, Anish, and pleasure to be part of this esteemed panel. Before I even move on to the question, and I was listening very intently to what Dr. Somesh had to say just before I spoke. I started speaking, and he was mentioning about, and I think it was also referred to by Mr. Naveen as well, on how early detection of early stage cancers leads to so much more benefits to the healthcare system overall and reduces the burden overall. In fact, I was just going through one of the papers that was published from one of the Latin American countries. I failed to remember which one, which very clearly, did a pilot project of, having mobile mammography screening vans across various, underserved communities in the country. They screened approximately around 18,000, 19,000 women, detected early stage breast cancer in around 6 to 7% of the women who weren't even aware that they have any kind of an issue. They also saw that when the program was implemented at scale at a larger level, they saw a clear shift in the pattern of the staging of the cancer at which it was presented into the clinic. A very very clear shift towards more and more females presenting at stage 1 and stage 2 rather than more advanced stages of breast cancer. They also did a very interesting economic evaluation of the entire impact, the cost of running these mobile mammography vans versus the total cost savings, and they saw a very very huge economic impact of running these kind of prevention campaigns as well. So sometimes at a policy level, I'm sure the cost benefit of some of these campaigns need to be evaluated, and some of these studies, very well done studies, can possibly continue to nudge us towards having much more structured prevention campaigns. Sorry, I couldn't hold myself back from quoting this very interesting article in context of some of the comments made by some of my fellow panelists. Now, coming back to your question, about strategies around prevention and control, and I think we need to first categorize and first drill down on what are the most important issues in relation to breast cancer diagnosis. I think Mr. Naveen very eloquently spoke about lack of awareness. I think the recent NFHS survey, the NFHS 5, if I'm not wrong, says that less than 10% of women between the age group of 15 to 49 in India have ever undergone any examination for breast cancer. Right, and there are several studies that reveal that irrespective of socioeconomic and educational background, there is a low understanding of breast cancer risk factors among Indian women. I think Dr. Shona and Dr. Anil also referred to the late health-seeking behavior among the women. Women's health being an often neglected aspect in Indian society. Also, there's been associated stigma, taboo, of fear of the unknown that prevent women from seeking healthcare benefits early on. The last one, which was spoken in bits, but really want to focus my attention there, was also around the lack of access, whether it's physical reach to any healthcare facility, especially in rural areas, the tier 2, tier 3 cities, and also in these healthcare facilities, prevention taking a lot lesser priority over active treatment of disease. That could be because of lack of enough infrastructure, lack of adequate number of trained workforce, and there are a number of reasons, right? So these are the most important issues, and I think industry in general and pharma in particular, which I represent, can play a very important role in shaping early breast cancer screening and diagnosis by partnering with the multiple stakeholders. One really good example is this particular forum itself, right? The IHW Breast Cancer Action Month, where you're kind of bringing together not only industry but other players, multiple stakeholders, to not only create awareness but also drive concrete actions amongst various groups so that we can prioritize and enhance the quality of care that we give to the breast cancer patients in India. I can also cite some other examples, and also just to break the monotony, I thought I'll probably interestingly cite some examples from non-oncology spaces that Novartis has been working on. For example, in cardiovascular space, Novartis supported a Beat Heart Failure campaign of Times of India to drive awareness of heart failure, a condition that is often misconstrued as heart attack leading to sudden death, but they are two different conditions. Very interestingly, the campaign garnered more than 330 million impressions in just 6 weeks of its initiation. More than 500,000 people took the symptom checker test. We developed a very easy to take symptom checker test thereby, educating people about the symptoms of heart failure, but also nudging them to seek advice and consultation if in case they find something wrong in the symptom checker. And several hospitals opened dedicated heart failure clinics post this initiative, just showing the power of collaboration and power of mass media in bringing awareness around some of these issues, right?
So, Dr. Gupta, I'll suggest to you to please do a poll like this, because whenever I go to Instagram, I see polls, see how you will die in the future, and see, are you prone to depression, take a questionnaire. So if, these questionnaires can be made to assess the risk of breast cancer, why not? I hope you and some people in the industry work on this as well, so that it becomes common knowledge. At least in the month of October, people take this poll. If they can take a poll on how I'll be at 65, will I die a millionaire or something like that, maybe if you check the risk of having breast cancer. So I request you and the other industry stakeholders to think about this and perhaps come up with something like this. Dr. Kumar, I wanted to find out from you, how many ASHA workers are there in Andhra Pradesh? Because in a state like Madhya Pradesh, they have a lot of ASHA workers, and just the scale of the number of ASHA workers, if they become aware of breast health, or how to do a self-examination, or how could things be wrong in a female breast, would be huge. If there are 2-3 lakh women who are doing the self-exam, it would be a lot of awareness. How many ASHA workers are there in Andhra Pradesh? And some of the other issues that were brought out was that ASHA workers have to be incentivized. They have a lot of work to do. NCD is a huge umbrella, and cancer is just one of them. Breast cancer is one of the cancers. So could you elaborate on the number of ASHA workers, and how can they be incentivized enough to ensure the awareness of breast cancer is high? Would request you to please unmute yourself, Mr. Kumar.
Yeah, more than ASHA workers, we also have a very strong A&M network. I think probably it's only state with the around 20,000 A&M workers for the state of 4.5 crores. I think no other state has it. So there is also something called Gramavada Sachivalayam. We have for every 2,000 people, we have a Sachivalayam where A&M is available. And we have other employees also, but A&M is available for the a particular Sachivalayam, which is around 2,000 people. And for this 2,000 people, there will be at least 2 ASHA workers. So in fact, I remember I personally did we piloted a camp where we had taken a bus, and then we were able to screen around 600 people. So one of the things I think Somesh and Dr. Pankaj have been doing this for, or Dr. Madam is doing it for some time, they would agree with me. Even if you put up an facility, bringing them to the facility for examination is very difficult. And so I think he was talking about, Dr. Sumesh was talking about clinical breast examination, right? So you have to go to a facility to do it. First awareness is the self-clinical examination. I think people are self-examination. People are talking about it. I think that's where we can start. I think that's the beginning. Instead of putting, and these are doctors, they will agree with me on this one. You will never know. You would have got yourself examined 2 months before, but there is a sign of cancer coming in after 2 months. Okay, so you can't keep yourself getting examined every 2 to 3 months. So it's the first thing, if you ask me, in the prevention, or maybe the primary prevention, that's the word properly used, right? So when you talk about the primary prevention, the first thing any woman should be educated is to examine herself. I think that's the most important thing. So I think there are a couple of videos. Shaili Chopra has done videos to explain. So we also made content in local languages. For example, in Telugu, in AP, to do it. So that is the beginning of your examination. And then when they feel there is something wrong, they'll always go to the second stage would be the clinical examination. And third could be, there is also a mammogram device which could be available. What we are planning to do is, for the tribal areas, we are putting that the smaller mammogram, it's not the diagnostic mammogram, smaller mammogram devices would be put. So we are looking at we have 35 mandals in tribal areas. That's the breast cancer is also happening in tribal areas. So we are looking at putting smaller units in these places, and also looking at buses. Buses would make a huge role, although it's very difficult to run a bus because you need a specialized bus to carry these mammograms. But that could help, because I remember there were older women. We actually, we interviewed them. why are you interested in getting examined? Because they think that the facility has come to them,
Hmm.
so it's better to get that examined, right? So that was one of
It's
the
more
motivations.
convenient for them also.
Yeah, and it's an expensive work. Okay, I think Dr. Somesh Kumar would know how difficult it is to carry a bus into a rural area, put it there, and get this thing. So if Novartis can, donate some 10 buses or 20 buses across the country, which we could take and use, because it's very expensive. Each bus would cost around 2 crores to, put it. And we are also planning to, buy some buses through CSR. And that's one of the things. Buses makes a lot of sense, right? That there are people. So the Adayar Cancer Institute, which has been doing this program for a long time, when we asked them, in fact, I spoke to them after my, camp. So I told them, sir, around 600 to 700 people came. They told me only 100 people will come in a day if you put a cancer camp. So the point is, it's not opportunistic cancer examination. You have to go, you have to go to the entire spectrum. It's not just you leave somebody, you test them, you get some 10% of the people into your system. You should be able to get at least 30 to 40% of the system to actually show results. So which means that the only way you can do it is super awareness driven campaign. I think Pankaj was right on talking about it. Unless you start this campaign. In fact, I remember yesterday putting a post on my Instagram telling that it's men's responsibility also to get their women examined, right? So that could be one of the campaign material around it. So that's important. I think it's a joint thing. And one more thing which could happen is a small initiative where we find a woman with breast cancer. Did we test all our relatives, all our offsprings, because they have a higher risk? Did we educate them? That itself controls a lot of things. So there are to be multiple strategies. It's not just going and examining them. For example, a lady with a breast cancer in the family. So I remember I have a friend whose mother died of breast cancer. She makes sure that every 1 year she gets her self-examined. So these are strategies we need to educate. I'm very sure you talk to your own friends whose mother had passed away in breast cancer, they would not worry
They're
about
not
it for
doing it. Yes. And we need
worry
a
about
buddy
for themselves.
system.
So
We need a buddy
these are
system
low hanging.
also.
What I call in government is low hanging fruits. We can easily educate them and get them going. So that's so it's super easy to get the awareness going. Only thing is getting them into doing it. For example, in fact, I asked why can't we go house to house and do it? Okay, women are not comfortable in their own household to get examined, though they're happy to come out and get themselves examined. And the distance is the criteria, so it should be less than a kilometer or two, so that they can come out and examine. I think Dr. Sumesh would know more than me because these guys have been doing it for a longer time. So that's my point. So we need to spread this word, not just with the rural women. Okay, it's our own. And I'm talking. I don't know how many of us really know how our cancer work. You ask anybody how does breast cancer come, nobody knows it. There are multiple ways of you get a breast cancer, right? So these are things I think it's not. I'm told that we are disease our society. In fact, we cannot even talk of having a BP as a problem, right? So I think we should get over that one. And if you find there is a difficult, I have an auntie who has had 2 bouts of colon cancer and she's still a survivor. So these are success stories. I think Dr. Shona was talking about 2 million people who are survivors. These are the stories which we have to tell, and we should make these women to come out.
Yes,
And
at IHW Council's shows, we do get our cancer warriors to talk about their experiences and give a little motivation to those who are undergoing treatment to see the light at the end of the tunnel and to be more motivated. Dr. Cruz, we are hearing a lot of strategies on how to increase awareness. Dr. Anil, Dr. Shona now gave us an example of one of our patients who had been treated for breast cancer and was not coming in time for a relapse. Now, along with awareness, what more needs to be done? Because she was aware, I had cancer, I got it treated, I got better, yet she didn't go to, get a cancer treated and relapse. So, what is the best way to, increase confidence when doing this increasing awareness? Is there a need for sensitivity? Should self-examination be stressed upon? Is it going to be effective? Because so far the data doesn't show this much. What would you like to say?
So, if I can respond to all the discussions that have happened till now, mobile vans going to screen, people going to houses to screen, ASHA workers to come in. I'm going to summarize everything with a very simple line. We need to strengthen our primary health services in the country. Today, we are talking about breast cancer and various models of breast self-examination, screening camps, awareness, dot. Tomorrow, it will be World Tobacco Day. We'll talk about oral cancer and discuss the same thing. Then we'll talk about lung cancer and we'll discuss the same thing. Awareness and strengthening our primary health system in the country is what's going to help us. How you do it? It should not be done in isolation. Naveen rightly said, if you cover 10% of the population, you won't see those kind of results. So my plea to all the big wigs on this panel is, let's not work in silos, look at breast cancer separately. Let's strengthen, and people like Naveen who are in government need to do that. Strengthen the primary health service across Andhra Pradesh, not only breast, you'll have a drop in cervix, oral, lung, and every cancer. And you'll get them at an early stage. So I don't want to make rambling comments about various methods. Someone did a study on self breast examination. I totally loved your point that it might show a shift in stage but not in mortality. There's no data on that as yet. So I just think we need to strengthen our primary health service, and we'll be good across all cancers and not only breast. I try to be as direct as possible rather than make comments and quote various type of studies and other aspects. So that's what I would like to say.
I have a comment, if I may make one.
Yes, please, ma'am. Go ahead.
Dr. De Cruz, there have been so many TV campaigns on lung cancer and oral cancer. Quite pictorial ones that have been coming from time to time. They're regularly aired. Has it made any difference to the situation in oral cancer that we're seeing?
So basically, because these are again in silos, like that mobile van that went out and did 10,000 people and it showed. There are no objective criteria to capture the impact, and these are done. If I can again stick my, just for individual quick glory that I did something, it's not a sustained effort. What's the point I'm making? Do a sustained effort, well orchestrated. Let's all collaborate together. Let's look at cancer as one disease. Let's have a good primary health system. Why are you only... So if you went to someone's house to look at that lady with breast cancer, why can't you look into the mouth of the husband for oral cancer? So Naveen is only wanting to do it for breast. In the same breath, he should say that it should be done for oral cancer as well and lung cancer as well. And that's the point I'm making, both as a clinician and administrator and as the immediate past president of the UICC. We have to do all together.
All right. Shona ma'am, I have a question to ask you. You gave us the example of your patient who had been treated in the past for breast cancer. And when it relapsed, she took her time to come to you. And you're saying that now that disease has progressed quite a bit. Now, there's effort being made to increase awareness. This patient knew what worked for her in the past. Now, despite the improvements in screening and treatment, are there inequalities of breast cancer among vulnerable women in India? Are patient navigation systems lacking? Does this increase disparities?
Of course, there's a complete lack of patient navigation system with respect to breast cancer. The lump gets examined somewhere. They go to a mammography to a second place. The biopsy is done at a third place. The PET scan is done at a fourth place. They are then shunted from the surgeon to the oncologist. And it's a piecemeal kind of picture because every center does not have the equipment to do everything together. So I think it's really up to the corporate hospitals and the private-public partnership that has to happen so as to be able to put the patient seamlessly through the flow and through the system because every time you send the patient somewhere else for an investigation, there is a danger the patient will fall through the system, will not get the test done, or will be lost in the system. And the time is wasted. Huge amounts of time are wasted. Sometimes it takes 2-3 weeks to get a PET scan appointment in public places or in, like through subsidized ways. So there has to be better coordination where places without the facilities or lacking have to team with places with facilities. And that's how we work it out. And we have to do it like that. And that's the biggest loophole, I think.
Mhm. Dr. Pankaj Gupta, would you like to come in here? Because Dr. Shona Nag is saying that there should be a collaboration of different stakeholders, including private companies, so that the patient navigation system becomes easier. Now, one of the reasons why health-seeking behavior in our country is not that important is because access is not so smooth. It is a pain to get treated, but it is a bigger pain to delay, and that people only understand in hindsight. So how can there be a collaboration to improve this patient navigation system? Because while Dr. Cruz is saying that primary health is very important, once the diagnosis happens, treatment also is important to get the confidence of patients. How can we make it easier for patients?
No, again, very valid points that have been spoken till now, and I love the direct comments from Dr. Nandir. Just set us all of us thinking, right? And I just wanted to also quote a small example from us. And I think there's Dr. Somesh also on the call. There was this initiative called Praram that we did a couple of years back with JHP EGO and the government of Odisha to streamline and coordinated and continuous breast cancer care in the state of Odisha. And it was basically intended at hitting the grassroots, strengthening the primary healthcare, and doing our bit to mobilize the community, increase the capabilities of the community health workers, provide them adequate communication tools in regional languages. Building capacity not only of those grassroots level workers, the community health workers, but across the care continuum, from awareness to diagnosis and care. And that is an initiative that was done a couple of years back. But I hear and kind of endorse Dr. Anil's point. There's a need to do a lot more of these initiatives at a far larger scale with far too many stakeholders. In fact, all of the stakeholders of the healthcare ecosystem coming together, which probably comes to your point, Anisha. And I just want to also point out the role of patient groups and the voice of the patients in possibly making some of these things happen. For example, we have collaborated with a lot of patient groups in India in the form of an alliance and partnership for patient innovation and solutions. It basically, we feel it's critical to include the voice of patients in healthcare policy making and delivery to make it acceptable and fit for purpose for the patients. So this initiative basically brings together the patient communities and brings them alongside some other key stakeholders of the healthcare system, including policymakers, payers, physicians, members of research community, academia, digital innovators, the startups, the health tech startups, to align on the key challenges and prioritize action towards better patient outcomes. I think all of these stakeholders not acting in silos, in small pilots, rather coming together and making that scalable one coordinated effort can possibly help make a much more efficient patient navigation system. Just before I kind of hand it back to you, and we were also talking about awareness all through the last 45 minutes in a different context: awareness of the general public, of the primary healthcare system, of the caregivers, of the patients. I think one important area is about awareness of modalities of access that we do not talk about very, very frequently. And not many of us probably know that the IRDAI, the insurance regulator in India, in 2019 expanded the remit of private insurance players and included a lot more modern therapies and innovative therapies within the ambit of these private insurance products. Now, I do understand, and a big disclaimer there, that less than 15 to 20% of the country's population do hold a private insurance, right? But there is also the Ayushman Bharat, which is doing so much for approximately 500 million patients in terms of supporting their inpatient care. but the private insurance has also expanded its coverage to the innovative therapies. Not a lot of patients obviously know about it, and the policyholders obviously don't know about it. But unfortunately, not even the healthcare practitioners, the clinicians, and the TPAs know about it. So I think that's also an area of awareness that all of us can come together, make each other aware of the possibilities of these financial access to some of these modern innovative therapies in a timely manner, so that the patient outcomes can be maximized. So just a few thoughts from my perspective on various stakeholders who can come together in a public-private or a private-private partnership model.
Right, a lot can be done, and I'm sure a lot is being done. Dr. Somesh, wanted to understand from you, since you have so much of on-ground experience, what is working? What are the things that actually work? Because Dr. Cruz is saying we need better primary health. Dr. Sharanag is saying we need a patient experience to be better. In your experience, what are the strategies that are working? One is to have ANMs, ASHA workers talking to people, getting them to come and screen. We've heard Mr. Naveen Kumar talk about taking healthcare to their doorsteps through a mammo bias, through doctor on call, personal family doctors, etc. What works? Because we have seen technology also really change the paradigm. See the example of COVID itself. You had a pandemic, and in our country we managed it pretty well. We had an app to get a vaccine. The large population of our country is vaccinated. That app worked. So things happen, and they happen quickly as well. What in your mind is working, and what needs to be worked upon so that you can see a multiplier effect quickly?
No, absolutely. I think the bottom line is, as I said, integrating into primary healthcare system, the care pathway into the primary healthcare system works. And we have seen that at reasonable scales. To Dr. Cruz's point, I think government is making a lot of investments in the primary healthcare systems through the Ayushman Bharat SWC program or various other initiatives by the state governments. And so we have to incorporate and integrate the cancer programming within those platforms. So that's why I said saturating the primary healthcare capacity with the early detection capabilities is very important. Whether you do it through the HWCs or through the PHCs or CHCs or all of the above. I mean, you will have to do all of the above. That has worked. What also works is decentralizing diagnostics. So once a woman is taken, she has had CBE positive, you need to make sure that the diagnostics are available close to her. So core biopsy with at least ultrasonography at the district hospital, that should be available. And again, decentralizing that diagnostic capability to the district hospital works. We have seen that. And then the third thing, most importantly, is patient navigation systems. We have seen, I'll share some data with you. We had 100,000 plus women whom we reached out to in one location. And out of those, 60,000 women turned up for clinical breast examination. Out of those, we had 4% women with clinical breast examination positive results by the frontline health workers. But out of those 4%, only 40% of those 4% reached to the next level of health systems for diagnostic. Just imagine 100 women having CBE positive, when she's told that aapko koi lesion ho sakta hai, you may be having some lesion. Out of that 100 women, only 40, actually 39 women reaching the district hospital or the medical college in that case for diagnostics. 61 that are not turning up for diagnostics. It's a big gap. And so strengthening patient navigation systems, either by digital mechanisms or any basic primary healthcare mechanisms, is very important. It has worked in other settings. We need to do that. But to everybody's point, saturating primary healthcare capability with early diagnostic and detection capability, decentralizing diagnostics to district hospital, we have seen in our big programs that it has worked. And you don't always need the mammography. Even a core biopsy with USG is enough for diagnosis at district hospital, as long as you do that at scale. Whatever you need to do, with at scale and with quality assurance. Over.
All right. A lot of ideas coming through. Dr. Naveen Kumar, in your mind, you spoke about the family doctor, also the whole facility of family doctor that you have. And you heard Dr. Anil also mentioned that, we should not work in silos. If a doctor is going to check the breast, they should also see other kind of cancer risk and then, holistically treat the entire family. What would you like to say here? Should we focus
remember
on...
my opening remarks was that I talked about common cancers, OBC. So it's not just you. That's the reason I started with it, saying that oral, breast, and cervical, these are the cancers which are detectable and preventable also at an early stage. So that's something which we are had to do. And also the news is, or maybe the fact is, 1/3 of your oral cancers across the world is in India only. So it's a bad news, so which are preventable. So it's not just since it was a breast cancer awareness thing, we had to talk about it. So the second point, I think Dr. Anil had spoken about public health care. If I think there are practitioners here, they would know that NCD is 65% to 70% of your disease burden these days. So which means that you need to have a strategy. So the strategy is the strengthening of the family doctor or the family physician concept. So we have started our experiments with it because we are trying to pull in the PSC, CSC network and also to the tertiary care as a single care continuum. So there's an experiment which is going on in AP for some time, and I think we will have a full scale launch somewhere in the I think Kerala already has a family doctor concept, so we are enrolling one of them, and then we'll have a full scale launch somewhere in January. So it's not just it is not just cancer which is a burden. It is the
NCDs.
one of the four of the NCD things, right? So we need to have a comprehensive. I completely agree with Dr. Anil, and the Tata Memorial has been the forefront runner for taking this awareness to the ground. In fact, their work in tobacco, making tobacco free institution is phenomenal. So it's not just. I have one more thing which I noticed among the oncologists. They are very passionate about preventive care because it's. For them, they always see patients which are at the end of life, right? So their hands are tied up. So they are very keen that the preventive care is it's the only way to stop the burden of cancer. I think that's why they are very passionate about prevention of cancer.
Okay, Dr. Naveen Kumar, can you elaborate on how this? Mr. Naveen Kumar, could you elaborate on how this family doctor system will work? Because honestly, about 30 years ago, every family used to have a family doctor, and for every small ailment, they used to go to them. But in urban cities, like say a large city like Delhi, the concept of family doctor seems to be on the wane. You have a cold and you go to an ENT doctor, or if you're coughing, you go to a pulmonologist. You land up straight to the specialist. So how does the family doctor work? How does this concept of family doctor try to overcome the hurdle of the problem of patient navigation and access?
Yeah, so if you remember, my opening remarks was that we have 6 A's of healthcare, right? One is awareness, accessibility, acceptance, right? So the third would be accessibility, availability, and affordability. These are the 3 things which government should take care of. So when you talk about public healthcare system, you would work on these 3 parameters. So you asked about family doctor. I remember talking to an liver surgeon in Hyderabad. He was talking about there are 16 specialized field only in liver, it seems, in USA. So it means that they're given so narrow that if you have an ailment, you have to go to one of them. And it's also it's coming back to where it started. So that's probably we need to strengthen our not just the doctor system, it's also we have to strengthen the nursing system, the pharmacy system. It's the comprehensive system which we have to strengthen. It's not just I don't know, we are not talking about another big time bomb which is there in the lurking behind us, which is called antimicrobial resistance. We give a lot of medicines without any care or something. So there are other things which we have to consider. So which means that the question you asked is, how do you give them access, right? So the public health care would move towards home care a lot. I think Andhra is one of the states where we have 104 system where for the older patient, the van goes to their house, examines them, and the prescription. So we are using the same network. Around 600 plus MMUs, the mobile medical units, would go house to house to a village, station themselves. And this would be, I think, we have made a plan for. We have a smaller unit called, it's smaller than a block, so it's called Mandal here in AP. So these doctors would go almost every alternate day to these villages allotted. They would have hardly 10 villages allotted to each of them. And there would be a doctor going to this village. And we also are using this Ayushman Bharat digital mission a big way, right? We have that AVA IDs, and these data are entered into that record so that the patient doesn't have to carry it. So this is the way we are looking at accessibility, where the patient is as an access. And combining with telemedicine, other things, I think Pankaj was also talking about how navigate the entire, the patient navigation. In fact, it's the most difficult part in cancer is the patient navigation. I remember talking to a couple of my friends, telling them what to do. You being a health secretary, they think you do not know it, right? So they go to a doctor, they listen to a doctor. So there is also an excellent system which was developed by Tata, which is called Tata Memorial, which is called Navia. So they also give you a second referral and all, right? So how many of us know that there's a system called Navia to get second referral? So these are things which we have to talk. Patient navigation is the key in cancer. I think, and there are specialized programs. I think there's a program called KVET in Tata Memorial, which talks about patient navigation. We need to, bring them to the ground level. I think the last mile, maybe the volunteers know a bit of patient navigation, the nurses know a bit of it. And cancer is not a single doctor disease, right? It's a combination of doctors who have to work on the cancer. I do not know, I think Dr. Somesh and Pankaj would agree with me. It's a combination of doctors. It's not just one doctor who will treat cancer. There could be a radiation oncologist.
Multidisciplinary.
Not multidisciplinary, it's itself within the oncologist only. You need like three kinds of oncologists to look at a single cancer case. In fact, I think if you have an immunotherapy, you even need a better trained doctor on it. So it's a complicated thing. So which means that patient navigation brings a very. I remember one of my dentists talking to a senior doctor. The comment made by the doctor was this one: you are the literate who went through off treatment. So imagine a dentist going through an off treatment, right? So that's the case with cancer. So it's not just easy. It's an easy subject matter to look at. It's not that easy. So patient navigation becomes very critical. And trust, I think that's the proper word I would think of. The trust in the system has to increase. And I think there is also a consensus guidelines which are coming up with the help of National Cancer Grid. I think if hospitals start using them as an platform to do it, the treatment part becomes better. That's my closing remarks.
All right. Dr. Pankaj, a lot of initiatives and possible actions Mr. Naveen Kumar has highlighted for us. Now, Dr. Somesh also spoke about his example when he said that when the bus went and the screening was done, a very small percentage of women who had a problem, who suspected to have a problem, actually went ahead for the treatment. So here, how do we overcome this? Do we need technology to do this, to overcome this whole problem of follow-up and then pushing them to take the treatment? Do we need a more sensitive approach to perhaps involve the family, sensitize the entire family that this treatment is important? How do we make this work while we need to get the private and the public stakeholders together? And in many places this is happening. Momo Bus is being sponsored by a private company, etc. But the follow-up to ensure that the treatment starts and goes till the end. What is needed? Is it technology? Is it sensitivity? Is it both?
You said it, Anisha. Actually, I think it's both, and probably more than that as well. And I'll probably speak about one particular aspect of this entire keeping the patient in the loop so that the patient continues to adhere to the right management protocol so that they can achieve the best possible outcomes at the end of it. That's what we are all aiming for as a healthcare system, right? So I think within that would be about how do we augment the quality of communication between the clinician and the patient is an important area of focus that we can possibly work on. For example, pharma companies do a lot in terms of medical education and treatment pathways, the latest guidelines, peer-to-peer experience sharing between the clinicians, but also a little unspoken and unknown kind of aspect is the work that is also done on patient counseling. For example, there are a lot of patient access programs that are run by the pharma companies, which also have a component of augmenting patient counseling through certified counselors to enable better disease management. And these kind of counselors kind of take over and partner and support the patient throughout the care journey, so that they kind of are, one, they provide the regular support, but also keep them encouraged and motivated to stay the course and adhere to the prescribed therapy. There are various other examples that we can take as inspiration from other therapy areas. For example, we ourselves are present in sickle cell disease. For example, we have a companion app that we have developed for patients that empowers patients and caregivers to plan, record, and maintain their health schedule. There is a component of vaso-occlusive crisis, a pain crisis that happen in sickle cell, and the patient can also report all of these reports with the doctor. It's also, what we've done is for the we've kind of have this app in regional languages so that it's much more usable and user friendly for a lot of patients. Secondly, there were a few comments on survivors and how survivors can be tapped to encourage and motivate other patients, right? So how do we foster these communities through digital tools, web portals or any other digital tool, to kind of help these patients come together, exchange their experiences, encourage each other to stay the course, is also one important use case of use of technology in augmenting patient support across the entire journey.
Right. I also wanted to, check with you, since Novartis is at the forefront of innovation, and the belief is that in our country, the innovation comes quite late. But all these innovations are underway to make it more customized and personalized treatment for patients. Do you think our health systems are ready to embrace this basic technological change? Because we do have the digital health mission, and it is, making a difference step by step. How do you think we can work together to bring the innovation to the last mile?
It's a fantastic question, and I firmly believe that it takes a village to raise a child, and it's the same case here. And I'll again repeat what Dr. Anil so passionately mentioned, multiple stakeholders. I think when you talk about is the health system ready, there are a few elements in the health system who are ready and very, very supportive of increasing the pace of access to the latest innovation. I think just from the expertise perspective of clinical trials in India. India is the clinical trial hub of the world, and not only for the world-class infrastructure and expertise, but also the burden of disease in India, which can possibly help these clinical trial run much more efficiently, which is also supported by a very, very progressive and forward-looking regulatory authority. I think the changes in the last 3 to 5 years that have happened to stimulate innovation, to support innovation, and to bring access to these innovative medicines. But even before the access to innovative medicines, to have Indian patients participate in the clinical trials so that there is enough robust evidence available so as to give us the confidence to bring these innovative medicines to India is also a critical element. And I think we should kind of doff our hat to some of the regulatory policies and frameworks that have come about in the last few years that have enabled that to happen. So I spoke about regulators, I spoke about the clinical trialists in the research community in the country, pharma companies. I think not only Novartis, but I think the endeavor of every pharma company is to ensure the broadest possible access to every therapy it comes out with. It's not just good science, it's good commerce. It's as simple as that, right? And that's why we are kind of committed to provide the best access to every possible patient subgroup across the world, not only in India, right? One important aspect there is how do we innovate? and what are we innovating in. For example, in breast care, breast cancer management, we would want to innovate and bring about therapies which work across a diverse set of breast cancer patients, and also therapies which kind of help some of the subgroup of breast cancer patients who have more worse prognosis. For example, in the first category, I would want a therapy that would be okay for premenopausal women and a postmenopausal women. I would want a therapy that can be used for male breast cancer patient. I would want a therapy that can work as a first line therapy or as a second line therapy. I want a therapy which can also be used in early breast cancer and in advanced breast cancer. So how are we innovating to produce such kind of therapies which can be used in a broader set of patients? And also the endpoint that we're looking at is overall survival. Are we meaningfully increasing the overall survival? Are we meaningfully improving the quality of life of the patients? I think those are the basic tenets on basis which we are kind of researching. And and I can say for sure a lot of progress have been made to provide these kind of therapies as well. Now coming to that question around personalization therapy, there is a case for standardization, but there's equally a case for personalization. And because evidence suggests that a lot of these standard therapies for cancer, which includes a permutation combination of surgery, chemotherapy, radiation therapy, immunotherapy, are effective in only about 50% of the patients. Now, why is that the case? Shouldn't standard therapy be okay for all 100%? It's not, because there is a very clear correlation with genetic mutation. There are certain genetic mutation basis which certain patients have higher risk for a certain type of cancer, and the prognosis and the survival also depends on these kind of genetic mutation. So naturally you will need to have specialized and personalized medications which are available for this patient subgroup as well, and that's where the role of these targeted therapeutic approach, and they being an equally important part in the armamentarium as long with the standard therapies come into picture. And just to kind of a closing comment here, a lot is said about the personalized medicine, and do we have the healthcare system to ensure that the innovation reaches the last mile? And companies like Novartis are happy to support with the healthcare ecosystem. For example, we have a targeted therapy for a breast cancer subgroup with a particular type of mutation called as PIK3CA mutation, a very specialized kind of a mutation. Such patients progress faster than the other patients. In India, Novartis assists patients with access to free PIK3CA testing. So that, because it kind of is very, it dovetails with a key goal of enabling access to testing so that patients are able to access the appropriate therapy as per their genetic predisposition. So I think there's a case for both standardization and personalization, but how all the stakeholders come together to kind of strengthen this ecosystem of personalized medicine is also an area of collaboration, multi-stakeholder collaboration moving ahead.
All right. Thank you so much, Mr. Gupta, for joining us and sharing your thoughts with us on our program. A very, very important step by us, by Novartis, to increase the awareness about breast cancer. Thank you so much for joining us. And I'd like to thank all our guests for taking the time to join us. Now, the phrase, the highest practicable level of health, refers to more than just the provision of medical treatment. It entails preserving people's health and avoiding the requirement for care. Now, as our panelists have pointed out, this calls for empowering and providing opportunities for people, families, and communities to make healthy decisions. And it also calls on the government to address the underlying cause of disease, and that are not just related to the health sector, in order to foster the favorable conditions for health to flourish in a holistic fashion. Now, our deliberations today have again highlighted the need to give primary healthcare more priority in order to build the foundation for universal health coverage with respect to breast cancer care. Now, particularly for health promotion and breast cancer prevention, this entails restoring, increasing, and maintaining access to necessary health services while also lowering the out-of-pocket expenses. It entails emphasizing the undeserved and the most vulnerable people, and making investments in the health workforce that has the education, know-how, equipment to provide high-quality, safe, and long-term care. To bring this event to a close, I would like to thank all our dignitaries that have joined us over the last few days for their expert insights and their efforts in making our country a healthier nation. I hope by working together, we may hasten the sharing of ideas and expansion of effective practices in the field of breast cancer control and care. We remain committed to doing our part to ensure that the nation can offer our people the highest caliber of breast cancer care. Thank you all for watching the show, and stay tuned to IHW Council's Facebook page for all the latest updates on our shows and the initiatives and the information nuggets that we bring you on health and well-being. Goodbye.
Thanks, Anisha. Bye.